Well, good afternoon to you all, ladies and gentlemen, and welcome to this session in which we are going to discuss coarctation and interruption. Those of you who have been following our sessions over the last few weeks will know that we have been considering malformations of the intrapericardial outflow tracts. Coarctation and interruption involve the extrapericardial outflow tracts. But as with my previous presentations to you in recent weeks, I'm going to start off by considering the developmental aspects of what happens to the extrapericardial pathways. And then I will discuss with you the anatomical features of these important lesions, coarctation and interruption. I'm going to start by considering the nature of the obstructive lesions themselves. I'm going to share with you where we find them. I'm going to emphasize the relationship with the arterial duct. And then I shall also place emphasis on the associated lesions, those that reduce flow, which we know to be particularly important in the setting of coarctation and interruption. But we're going to start off by looking at development, because what we are concerned about this week is what happens to the extrapericardial arterial pathways. Over the past 2 or 3 weeks, we've been discussing the anatomy, the development, and the malformations of the intrapericardial arterial pathways. And last week, we concentrated on what happened to those lesions involving the ventricular outflow tracts in subvalvar, valvar, and supravalvar level. So now we are going that extra step, and we're going to look at what happens to the pathways outside the pericardial cavity. And this means we have to look at what happens to the branches of the aortic sac. So to know that, you need to understand what I mean by the aortic sac. What I'm going to show you very shortly is that the aortic sac is the manifold that's contained within the pharyngeal mesenchyme. And it gives rise to the arteries of the pharyngeal arches. They are going to be the more important next week when we discuss aortic rings and slings. So I'm going to set the scene this week for the discussions that will then continue over the next 2 weeks as we discuss those rings and slings, and then eventually what happens to the so-called fifth arch artery. And to do all this and to put it into context, I'm indebted again to these wonderful reconstructions that have been made by my good friends and colleagues, Professor Wout Lammers and Dr. Jill Hickspoors, who work in the University of Maastricht in the Netherlands. And those of you who have been watching my presentations during this series will know that I've been using these reconstructions, which show the changes in human development as we move from 4 weeks or so at what we call Carnegie stage 10 to the end of the embryonic period at Carnegie stage 23. So here I'm showing you a reconstruction of the right side of a human embryo at Carnegie stage 14. And you will see this is 35 days, more or take, of development. So about 5 weeks of development. And one of the beauties of these reconstructions made by Wout and Jill is that you can take them apart and you can put them back together because they are interactive PD reconstructions. So I'm showing you the reconstruction from the right side. What I want you to concentrate upon are these areas now that are shown in gray, because these are the outpouchings from the developing pharynx, and we call them the pharyngeal pouches. So there is the first pharyngeal pouch. And initially, it had an artery running through the pharyngeal mesenchyme associated with it. That was the pharyngeal mesenchyme of the first arch, but the artery by now has attenuated. If you look caudally, you can see the second outpouching. And between the second pouch, the first pouch, we have the second pharyngeal arch. And that also had an artery percolating through it, but that artery by now has also attenuated. But then if you look further caudally, you'll note that there is the third outpouching. And this time there is an artery that is running through the third pharyngeal arch. So this is the third arch artery. You should take note of its color because Wout and Jill have retained that color through the remaining reconstructions that you're going to see, which will take us up to the end of the embryonic period. Let's look again at this initial embryo, and you see we have a fourth pouch. So we have a fourth arch, and running through that fourth arch, we have the fourth arch artery. But then you see we have an additional artery that is percolating through a segment of pharyngeal mesenchyme. Now, in the past, we've called this the sixth arch artery. But what I'm going to emphasize in 2 weeks' time is that we never have formation, neither in the human nor in mammals, never do we find formation of a fifth pharyngeal arch. So now I'm going to call this segment of mesenchyme the pulmonary arch, and I'm going to call the artery running through it the pulmonary arch artery. Because what I'm going to show you is that it is this segment of the aortic sac that forms eventually the part of the system that gives rise to the right and left pulmonary arteries and continues as the arterial duct. But let's come back for a moment to the aortic sac, because here we see beautifully what we mean by the aortic sac. This is a dissection of a human embryo that was made quite some time ago now by Szabolcs Virag. Sadly, Szabolcs is no longer with us, but he was an outstanding anatomist, embryologist, and he worked in Budapest. But when he made these dissections, he was working together with Wout Lammers when Wout himself was still working in Amsterdam. And Szabolcs has made this dissection, and it has been visualized using scanning electron microscopy. And what Szabolcs has done is taken away the pharyngeal mesenchyme at the junction of the distal outflow tract with the aortic sac. So there you see the cavity of the distal outflow tract. If you look at its walls, we see the margins of the pericardial cavity. And by dissection, Szabolcs has shown you that within the pharyngeal mesenchyme, we find this cavity, and we call this cavity the aortic sac. And now you see very nicely that arising from the caudal part of this cavity, just beyond the margins of the pericardial cavity, we see the symmetrical openings of those arteries that are percolating through the pulmonary arches. And then when we look more cranially, we see the opening of the fourth arch arteries, and they continue, and there we see the openings of the third arch arteries. So now let's put this back into the context of the reconstruction made by Jill and Wout. In fact, what I'm showing you here is a reconstruction of a CS13 embryo. The reconstruction I showed you in PD format was a CS14 embryo, but there's very little difference at this early stage in the aortic sac. So this is what it looks like in the CS14 embryo. As you see, again, 35 days, 5 weeks of development. So within the ventricular loop, we can see the developing right ventricle. The developing right ventricle, as we have discussed, is giving rise exclusively to the outflow tract at this stage, and the outflow tract has a solitary cavity moving to the margins of the pericardial cavity. And there it becomes the aortic sac, because the aortic sac is extra pericardial. And we can already see that the aortic sac has two horns, which are giving rise to the arteries of the third arch and the fourth arch. And at this stage, there is symmetry. So the artery is percolating through the pharyngeal mesenchyme at this stage on both sides, encircle the developing cut, and give rise to the dorsal aortas, as do the pulmonary arch arteries, which at this stage are also bilaterally symmetrical. So on each side, the arch arteries give rise to the dorsal aortas. The dorsal aortas come together in the midline. But just above their point of union dorsally, they give rise also to these very important arteries, the seventh cervical intersegmental arteries. And I'm going to be tracking what happens to these seventh cervical arteries. So now let's see what happens to these extrapericardial pathways with the passage of time. And we can do that by moving through the Carnegie stages. So here, one step further, only 1 day has passed since the last stage, but there have been significant changes within the heart itself. We still have a common outflow tract which extends to the margins of the pericardial cavity, but that is now giving rise to the ascending aorta, and as we will see shortly, the pulmonary trunk. We can now see the horns of the aortic sac. And if we look at what is happening to the right horn, we see that the right horn continues as right fourth arch artery, but the right fourth arch artery is giving rise now to the right third arch artery. That then continues as the right dorsal aorta, meeting again the right fourth arch artery. Turn your attention to the left side, and still we see symmetry. So there cranially, the left third arch artery running in parallel with the left fourth arch artery, a little bit of space, and then arising from the caudal part of the aortic sac, which by now from its floor is giving rise to developing right and left pulmonary arteries. They are percolating caudally towards the developing lungs, running down within the pharyngeal mesenchyme, but arising also from this caudal part of the aortic sac, we have the two pulmonary arch arteries. And then still arising from the dorsal aorta, we have the seventh cervical intersegmental arteries. Now I want you to take particular attention of what's going to happen to these seventh cervical intersegmental arteries, because they are going to move cranially relative to the heart. In fact, the heart itself is moving caudally because those seventh cervical arteries are themselves fixed within the walls of the developing embryo. So let's move on, another Carnegie stage. We've now moved to 38 days of development. We're towards the end, the 6th week of development, and now the distal part of the outflow tract is dividing into the intrapericardial components of the aorta and the pulmonary trunk. So there now we see the ascending aorta, and we can see that extrapericardially it's dividing into its two horns. So on the right side, there is that small component of the fourth arch, which gives rise to the right third arch artery. There is still persistence of the dorsal aorta on each side between the terminations of the right third arch artery and the terminations of the right fourth arch arteries, and we call those the carotid ducts. They will very soon disappear, but they can persist and they can be involved in producing malformations. But on the left side, we still see the parallel arrangements of the left third, left fourth arch arteries, and still we see that arising from the caudal part of the aortic sac, we have the right and left pulmonary arteries. But now look what is happening to the pulmonary arch arteries, because now the left pulmonary arch artery is becoming dominant. There is attenuation of the artery running through the left pulmonary arch. And look also at what's happening to the 7th cervical intersegmental arteries, because these arteries are moving cranially relative to the developing heart. So we move on another stage, Carnegie stage 17. We're nearly now at the end of the 6th week of development. But what we can see now, we discussed this last week, within the outflow tract itself, the intrapericardial outflow tract, the intermediate part has now separated into the aortic and the pulmonary roots. If we look at the developing ascending aorta now, we can recognize clearly an intrapericardial part, an extrapericardial part. That extrapericardial part now itself continues as the horns of the aortic sac. So there is the right horn giving rise to the right fourth arch artery, and also giving rise to the right fourth arch artery. The right fourth arch artery itself continues to give rise to the right dorsal aorta, and now you can see that it in turn is feeding the right 7th cervical intersegmental artery. If we look at the left horn, that gives rise to the left 3rd arch artery, continues as the left 4th arch artery, and now look what is happening also within the distal extent of the intrapericardial component of the outflow tract, because it has become the intrapericardial pulmonary trunk. And it, as it exits from the pericardial cavity to become continuous with the caudal part of the aortic sac, now gives rise to the dominant left pulmonary artery, with ongoing attenuation of the right pulmonary arch artery. And at the same time, there is ongoing cranial movement of the 7th cervical artery. So now we move on to the beginning of the 7th week of development, 43 days, 6 weeks have passed now. We see again the intrapericardial, the extrapericardial components of the ascending aorta. And now there is development of that right horn of the aortic sac, such that it is a common channel. It's giving rise to the right 3rd arch artery, the right 4th arch artery. And look how that cranial migration of the right cervical arteries in such a way that the persisting component of the right dorsal aorta is itself attenuating. And eventually that too is going to disappear, as I'll show you in the next stage. So the left horn we can now recognize as the beginning of the transverse arch of the aorta. And it's giving rise to the left 3rd arch artery, continuing as the left 4th arch artery, and the left 7th cervical intersegmental artery is now opposite the junction between the left pulmonary arch artery and the dorsal aorta. And this is very important when we consider coarctation and interruption. So here at Carnegie stage 20, we are more or less into the postnatal configuration. There are still changes to be made, but now I can show you what has happened to produce essentially the postnatal configuration. So let's look at that right horn, that extrapericardial component of the aortic sac, which gives rise to the right horn, which we can now recognize as the brachiocephalic artery. And you can see the brachiocephalic artery is giving rise to the artery of the 3rd arch, which we can now recognize as the right common carotid artery. It continues as the artery of the 4th arch. There you see it, note the difference in color. And that is now supplying the 7th cervical intersegmental artery, which will become the right subclavian artery. So very nicely now, you see how the right horn feeds the right common carotid, the right subclavian arteries, the right horn recognizable as the brachiocephalic artery. So now we see that the left horn of the aortic sac is recognizable as the first part of the transverse arch of the aorta. And that is giving rise to the left 3rd arch artery, which we can now call the left common carotid artery. We then have a small part of the left fourth arch artery, and that is forming now the transverse, the second component of the transverse arch. But here is the key point. The left seventh cervical intersegmental artery has migrated across the union between the arterial duct, which was the left arch artery, and the descending aorta. And that has now permitted us to recognize the isthmus of the aorta. And it is this crossing of the union between the arterial duct, the descending aorta, by the left subclavian artery that is the key to understanding the formation of the isthmus of the aortic arch, which is going to be so important as we discuss coarctation. So hopefully you will see how this developmental information now permits us to understand precisely how we get the formation of these extrapericardial arterial channels. And this is the background to what I now want to discuss with you in the setting of coarctation and interruption. And I'd like to discuss this with you in the setting of a spectrum of malformation. So the mildest end of the spectrum is coarctation. And as you all know, patients with coarctation themselves can have mild coarctation, they can have severe coarctation. Oftentimes, in fact, usually, coarctation is associated with a degree of isthmal hypoplasia. But when it is more severe, we also find hypoplasia of those components of the aortic arch. And that's why these segments of the aortic arch are so important. And we're going to discuss that next week in the setting of rings and slings. But today, I'm going to discuss that with you in the setting of tubular hypoplasia. I'm going to show you how, with more severe disease, we can have atresia of these components of the aortic arch. And then eventually, those atretic components themselves can disappear entirely. And we see this spectrum of malformation, as I'm going to show you, most obviously at the level of the isthmus of the aorta. So here is what we see with coarctation itself. It is a narrowing. What you see is the pulmonary trunk meeting the isthmus, continuing as the arterial duct into the descending aorta. And here we have that narrowing, that coarctation at the union between the isthmus, the arterial duct, and the descending aorta. So it is this narrowing that we identify as the coarctation lesion. But in most instances, that is also associated with an additional narrowing down of the isthmus itself. And this is what we call isthmal hypoplasia. And you see this waist-like arrangement where the cavity of the isthmus narrows down as we move, in this particular instance, from the origin of the subclavian artery towards the duct feeding the descending aorta. But we can also have tubular hypoplasia. And now in this particular specimen, you see the importance of that cranial movement of the subclavian artery derived from the seventh cervical intersegmental artery. Because there is tubular hypoplasia of a segment of the aortic arch, but this is not the isthmus. Because look, that terminal branch of the major part of the aortic pathway at this stage is the left common carotid artery, and there is the left subclavian artery. The seventh cervical intersegmental artery in this particular individual did not migrate across the union between the arterial duct and the descending aorta to form the isthmus. But in this specimen, it certainly did. And this is the extreme form of isthmal hypoplasia. Because if you look at the aortic pathway, you can recognize to your left hand brachiocephalic artery, itself branching into right common carotid, right subclavian artery. Then you see the origin of the left common carotid artery, then the left subclavian artery, and then beyond the left subclavian artery, we have this atretic segment of the arterial pathway. So this is atresia of the aortic isthmus. And then you don't need much to appreciate that the next step beyond atresia is interruption. So here is interruption at the isthmus. So look again at the extrapericardial arterial pathway, and you can recognize brachiocephalic artery, left common carotid artery. There is the left subclavian with a little branch coming off the left subclavian. And then shown by the double-headed arrow, we have interruption of the part of the arch that should have been present between the left subclavian artery and the descending aorta. So there you see the intrapericardial aorta, and now I can show you the importance of distinguishing between what is intrapericardial and what is extrapericardial. Because here, in this particular specimen, between the aorta and the pulmonary trunk, we have an aortopulmonary window. And the essence of the aortopulmonary window is that it is intrapericardial, and it is a malformation of that distal part of the intrapericardial outflow tract. So beyond the pericardial cavity, and we've taken away the pericardium in this particular individual, we see the arterial duct, and always the arterial duct is extrapericardial. And in this setting, as we will emphasize in the setting of interruption, it is the arterial duct that feeds the descending aorta. So that is the spectrum of malformation best seen at the isthmus. So what about the obstructing lesion itself? Because it can take markedly different forms. Usually we see it as a waist lesion. But then when it is severe, we look inside the cavities of the proximal and distal parts of the arterial pathways, we find a shelf forming a diaphragmatic obstruction within the lumen. But as I've shown you, we can also have associated tubular hypoplasia, and we see that in the most severe forms of malformation. So let's illustrate what we mean by these different entities. So here is a drawing showing you the waist-like infolding of the walls of the arterial pathways. And I've shown you this picture before. I show it to you again because it shows you very nicely how the association of isthmal hypoplasia and infolding of the walls produces the coarctation lesion. And there, in this instance, I'm going to emphasize this again very shortly, the coarctation lesion itself is in front of the arterial duct. So another key feature is the patency of the arterial duct and the relationship between the arterial duct and the obstructing lesion. Because when the narrowing becomes more severe, we can get this formation, a shelf within the lumen. And most typically, we see that when the arterial duct is closed. In the old days, we used to call this the adult form, and we used to call the association with the open arterial duct the infantile form of coarctation. But nowadays, most time coarctation is diagnosed during the neonatal or infant period, although it can still be a problem in diagnosing coarctation, and you will all know better than I that on occasion, coarctation can be diagnosed as the cause of hypertension in adults. But this is what we see coarctation like when it's resected at surgery, a pinhole opening, and it is a shelf formed between the proximal and the distal parts of the arterial pathways. So where and how do we find and describe the obstructive lesion? And this is where the duct becomes so important again, because the obstructing lesion in most instances in front of the arterial duct, it is pre-ductal. But it can be opposite the mouth of the arterial duct, And on very rare occasions, it can be distal to the mouth of the open duct. I must admit, I've never seen such a case. But I can illustrate to you the situation, because most usually we see that waist lesion, as I've shown you here, which is in front of, cranial to, the mouth of the arterial duct. And that is what we call pre-ductal coarctation. More rarely we find that the waist-like lesion is opposite the mouth of the duct, and so that is paraductal coarctation. And then, as I say, very rarely the coarctation lesion can be distal to the mouth of the duct. Postductal coarctation, I emphasize again, I've never seen an autopsy example of postductal coarctation. Now, many of you will call these lesions juxtaductal. I don't particularly like the term juxtaductal, because all of these encroachings, all of these obstructive lesions are around the duct, juxtaductal. So I would much prefer to distinguish them as being preductal, paraductal, and very rarely postductal. So the one you've now seen already twice, this is a beautiful example of preductal coarctation. There is the narrowing, and when we trace the mouth of the arterial duct, it's in direct communication with the descending aorta. Here is a nice example of what we see when the coarctation lesion is opposite the mouth of the arterial duct. And this time it is manifestly paraductal. And you will follow, I don't have an example to show you of postductal coarctation because I've never seen one. But let me emphasize to you the role of the arterial duct. When I started in the field, this itself was controversial. But we've now resolved the situation that the shelf lesion is made of ductal tissue. In fact, the evidence was already there that the shelf lesion was made of ductal tissue. Some very elegant work done in Leiden, even before I became involved in the field, by Wielenka and Dankmeier, showed without question that the coarctation lesion was made of ductal tissue, but people did not always believe it at that time. But what Wielenka and Dankmeier showed was that in the normal heart, there was a degree of extension of ductal tissue into the channel between the arch of the aorta and the descending aorta. And that's what I'm showing you in this picture, because we can distinguish what is ductal tissue, because the walls of the arterial duct are muscular, whereas the arterial walls are quite different. They have the mixture of collagen and fibrous tissue and smooth muscle cells within their walls, and it's the layered arrangement that permits us to distinguish between the walls of the duct and the walls of the other arterial pathways. And what Wielenka and Dankmeier showed a long time ago now, in the 1950s, was that in the presence of coarctation, this ductal tissue lassoed the union between the isthmus and the descending aorta. But as I say, when I started in the field, there was controversy as to whether this was a real thing. There was much evidence, in fact, to support the notion that it was real, because when you look at these specimens, as you see here, you can see this pale tissue, which is ductal tissue, and you can intuitively feel that this ductal tissue is encircling the mouth of the arterial duct. But in fact, it was Xu Yen Ho, who was working with me at the time, at the beginning of the 1980s at the Brompton Hospital, and she did a thesis looking at the role of the arterial duct. And this is one of her beautiful pictures. And it was Yen who first confirmed and endorsed the results of Wielenka and Dankmeier, confirming the role of the ductal tissue. And Yen's section here shows you exquisitely the difference between the walls of the isthmus, the walls of the arterial duct. You see that the isthmus, the duct are coming together to form the descending aorta, But in this fibrous tissue stain, you see that there is no fibrous tissue within the walls of the arterial duct. The walls of the isthmus, however, are continuous with the walls of the descending aorta, and clearly you see their arterial phenotype. This is not muscular, this is an arterial wall. But there you see the coarctation lesion, unequivocally made up of ductal tissue. And then this work was then further confirmed by Nienke Elsinga, who was working in Leiden, who confirmed again the initial findings of Wielenka Dankmeier, which themselves had been endorsed by Jan Ho, who has subsequently become the professor working at the Brompton Hospital. So that's the story about coarctation. Let's now look at interruption, because as I've shown you, interruption is the end point of the spectrum of obstruction of the aortic arch. And the key here is the site of interruption. So I've already shown you the progression through isthmal hypoplasia, atresia of the isthmus, to interruption of the isthmus. And this is where we best see the spectrum of malformation. And I like to consider this as interruption at the isthmus, but those of you who use alphanumeric categorizations will know this as interruption type A. Probably the commonest form of interruption, however, is interruption between the left common carotid and the left subclavian arteries. This is the association with the one that goes along with neural crest malformations. It's part and parcel of the genetic syndromes. The interruption at the isthmus is much more associated with flow problems, but this is the one that is genetically modified. The problem comes in recognizing the influence of retroesophageal origin of the right subclavian artery, because that can give the Y configuration of the ascending aorta that is typical of the rarest form of interruption, namely interruption between the carotid arteries. And for those of you who like the alphanumeric categorizations, this is type C, very rare, commonest type B, second commonest interruption at the isthmus. So either coarctation or interruption can be found as an isolated lesion. Interruption at the isthmus most frequently when found as an isolated lesion, is associated particularly with collateral circulation. I'm not aware of interruption between the right common carotid and the right subclavian arteries as being found as an isolated lesion. I think almost always that variant is found with an arterial duct, but interruption at the isthmus, coarctation, can certainly be found in isolation. But most typically, we find these lesions with associated lesions within the heart, and these, one of them outside the heart. I was a little bit ahead of myself there, because particularly important, retroesophageal origin of the subclavian artery. We're going to discuss how that comes about next week, because that is the commonest form of so-called aortic ring. But we can have that in association both with coarctation and interruption. But to finish, I'd like to concentrate on those lesions which reduce the aortic flow, because these are the ones that we look for in the setting of coarctation or interruption. On the other hand, when we find these lesions, they point us towards looking for coarctation or interruption. So there they are listed: ventricular septal defect, infundibular obstruction, and then the univentricular atrioventricular connection with a restrictive ventricular septal defect. But let's start by looking at the ventricular septal defect in isolation, or rather when associated with aortic coarctation. Because classically, we are looking at deviation of the outlet septum into the left ventricle, and that, as we have seen before, will narrow the subaortic channel. But when we looked at a series of hearts from Pittsburgh with coarctation, we were surprised to find that we could also have coarctation in association with deviation of the outlet septum into the right ventricle. So let's look at these different patterns of deviation of the outlet septum. So here I'm showing you the roof of the morphologically right ventricle, and there you see the muscular outlet septum, and it is deviated through an associated ventricular septal defect, and it has narrowed the subaortic outflow tract. As we look at the posterior inferior margin of the defect itself, it has a muscular posterior-inferior rim. But this is the other side of the coin, and this again is the base of the heart from a patient who has aortic coarctation. And what you see very nicely here is the aorta overriding the crest of the muscular septum. We typically see this in the setting of tetralogy, but in this individual, the pulmonary outflow tract was unobstructed. But what we do see relative to the crest of the outlet septum is that there is narrowing of the left ventricular outflow tract by an anterolateral muscle bundle, a muscle bundle described initially by André Moulin, the pediatric cardiologist who worked in Leuven. And there you see tissue tags blocking the right ventricular entrance to the overriding aortic root. And so here we are narrowing again the pathways into the aorta, and this is one of the associations with aortic coarctation. With interruption, we anticipate the ventricular septal defect will always be associated with posterocaudal deviation of that outlet septum. But the caveat here is that the outlet septum itself can be fibrous rather than muscular. So this is the typical arrangement. I'm showing it to you here from the right side. And there, as we look through the outlet ventricular septal defect, we see the deviated muscular outlet septum in association with interruption of the aortic arch. But here is the caveat, because here again, we have deviation through the outlet defect, but this time it is a fibrous raphe, once more with interruption of the aortic arch. And so this is what we see when the outlet septum is muscular. There it is. It's deviated in the outflow tract. Note that there is also still a freestanding muscular subpulmonary sleeve, but the whole thing has moved into the left ventricle, narrowing the subaortic outflow tract and producing interruption of the aortic arch. But this is the other side of the coin. The whole thing has moved caudally, but without any muscularization to form a subpulmonary infundibulum. So instead, we have a fibrous outlet septum, but that fibrous outlet septum is still deviated posterocaudally, narrowing the subaortic outflow tract and giving us the same end product, interruption of the aortic arch. So let's look at the restrictive infundibulum. We find this either with double outlet right ventricle or discordant ventricular arterial connections. The key here, the defect itself will be subpulmonary. And this is what we call the Tausig-Bing malformation. And oftentimes, going along with that, we have straddling and overriding of the mitral valve, as you see here. You're looking up into the roof of the right ventricle, which in this instance has double outlet. There you see a probe that has been placed through the narrowed subaortic infundibulum. But look at the defect itself, which is subpulmonary. Coming through the subpulmonary defect, we have a cleft overriding and straddling mitral valve attached to the muscular outlet septum. But to add to the problems, the narrowing of the subpulmonary infundibulum has produced severe aortic coarctation. These are the problems that we anticipate in the setting of the Tausig-Bing malformation. So let's finish by looking at the final situation you should always be anticipating when you have discordant ventricular arterial connections in the setting of univentricular connection to a dominant left ventricle. Because in this setting, restriction at the level of the ventricular septal defect is subaortic. And we can find this with double inlet left ventricle, with tricuspid atresia, or when there is absence of the left atrioventricular connection, mitral atresia, if you will, but in this setting with a leftward incomplete right ventricle, it would be tricuspid atresia had the connection been formed. So better to think of it as absent left atrioventricular connection. The end result is the same. So here I'm showing it to you in the setting of double inlet left ventricle. There is the dominant left ventricle receiving both the inlets. The right ventricle of necessity is incomplete. It's giving rise to the aorta, and their restriction at the ventricular septal defect will prevent all the flow going up into the aorta. And this is what it looks like in its extreme form. I've positioned the heart this time as the surgeon might see it in the operating room, because there may be a case to enlarge this restrictive ventricular septal defect. So there you see it. The blood is coming from the dominant left ventricle into the incomplete right ventricle and into the aorta. And so producing obstruction within the aortic pathway is the restrictive ventricular septal defect. Should the surgeon wish to enlarge this defect, he or she must avoid the conduction axis. So where is the conduction axis? We know that the conduction tissue is carried on the crest, the muscular ventricular septum. We know that the atrioventricular node is carried in the right atrioventricular orifice. So join the two together, and that tells you, or tells the surgeon, the location of the conduction axis. So where is it safe to resect? It is safe to resect a segment of septal myocardium closest to the obtuse margin of the ventricular mass. So all of this together emphasizes the point that we made last week. When you find obstruction to aortic flow, you should be thinking about coarctation or interruption of the aortic arch. And interruption itself is the worst end of the spectrum of obstruction of aortic flow. So I'll finish again with the aphorism I shared with you last week from my good friend Richard van Praag. In the setting of coarctation and interruption, all the woe lies below. But next week, we're going to look again at what happens to the extrapericardial pathways as we discuss aortic rings and slings. So I'll be revisiting with you the developmental considerations with which we start this presentation.